Hi everyone, I am Ali Yıkılmaz. I'm a pediatric radiologist at McMaster Children's Hospital, and I'm going to talk about ovarian torsion. If we look at the anatomy, we can see the adnexa of the uterus. Adnexa means appendage, so we are looking at the appendages of the uterus. These are ovary, the fallopian tube, the ligaments of the ovary, which is the ovarian ligament medially and suspensory ligament laterally, and these are all called adnexa, along with the broad ligament. If you look at the vasculature of the ovary, there is the ovarian artery and vein supplying both the ovary and the tube going through the suspensory ligament. That's why it's called the vascular pedicule. And there is also the uterine artery and vein supplying the ovary and the fallopian tube. This is called dual vascular supply of the ovary and the fallopian tubes. So what is torsed in the ovarian torsion? Obviously the ovary, but also the fallopian tube. Commonly, both the ovary and the fallopian tube torse. Isolated ovarian torsion is rare. The ovary is twisted along with its ligaments, the ovarian ligament and the suspensory ligament. Suspensory ligament is important because it consists of the ovarian artery and vein and causes uh, vascular compromise. So it is more accurate to call this torsion of the adnexa rather than torsion of the ovary because isolated ovary is not a common presentation. Let's look at some numbers in this slide. 4% of children presenting with abdominal pain in ED is ovarian torsion, and it's more common in adults than children. Only 15% of all ovarian torsion is seen in pediatric population. They are commonly associated with an adnexal mass, benign adnexal mass, 51 to 84%, and these masses are usually follicular or luteal cyst or mature cystic teratoma. The risk of torsion correlates with cyst size and is greater when cysts measure 4 to 5 centimeter. A normal ovary can also be torsed, less commonly, 16 to 49%, and torsion in a normal ovary is more common in children than adults. A torsion associated with an adnexal malignancy is extremely rare. We almost never see it in children. There are two peaks for ovarian torsion in children: perinatal, usually more commonly prenatal, and early adolescence and immediate post-menarchal years. And this is corresponding to 9 to 11 years old. So a 6-year-old child would be less likely to have ovarian torsion. Clinical presentation of ovarian torsion is typical. Acute pelvic pain, which is intermittent, is typical. Nausea and vomiting, up to 85%, is seen in most patients, and this is a more common finding in pediatric patients. Ovarian torsion is a surgical diagnosis. There are no clinical or imaging criteria sufficient to confirm the preoperative diagnosis of torsion. Don't forget. The treatment is surgical. If ovarian torsion is suspected, timely intervention with diagnostic laparoscopy is indicated to preserve ovarian function and future fertility. A minimally invasive surgical approach is recommended with detorsion and preservation of adnexal structures, regardless of the appearance of the ovary. A surgeon should not remove a torsed ovary unless oophorectomy is unavoidable, such as when a severely necrotic ovary falls apart. In the past, they were removing the torsed ovary, but no, the current approach is to leave the ovary as possible. If we look at the clinical algorithm, a patient presents to ER with abdominal pain, and we do an transabdominal ultrasound because they are children, and if our findings are suggestive of torsion, such as enlarged heterogeneous ovary, asymmetric ovaries, multiple peripheral follicles, or whirlpool sign, the patient goes to laparoscopy. If our findings are not suggestive of torsion, such as normal ovarian size and position, symmetric ovaries, and if the pain persists, then evaluate for other etiology. If the pain resolves, then observe and also consider intermittent torsion. What are these imaging findings? These findings are similar in ultrasound, CT, or MRI. The most consistent finding is unilateral enlargement of ovary, which is more commonly on the right side, 1.5 times more common. This is believed to be the secondary to the cecum, which is located on the right side and pushes the ovary medially. Associated mass, heterogeneous ovary due to edema, necrosis, or hemorrhage, increased stromal echogenicity, mass-like ovary. Sometimes ovary appears very heterogeneous and looks like a tumor, like a mass. Randomly distributed follicles rather in the periphery, which is very typical. Midline or contralateral position of the ovary. Whirlpool sign of the twisted vascular pedicle is a very reliable sign. Ovarian tenderness to probe pressure. This is a subjective sign. Free fluid is common, seen over 80% of the cases. Absent or little venous flow is a common finding. Absent arterial flow is a less common finding and seen in delayed cases. So, when both ovaries are normal in size and location, ovarian torsion is essentially excluded, and additional imaging, such as Doppler ultrasound, is not necessary. You can even diagnose on the grayscale ultrasound, and no disclaimers required in your report. Let's look at some examples. This is a case with ovarian torsion on the right side. If you compare with the normal left side, there is unilateral enlargement of the ovary. It's on the right side. It's heterogeneous. There's increased stromal echogenicity here, and also randomly distributed follicles rather in the periphery, and there is free fluid. The flow is not impaired, as you can see. There is still arterial here and venous flow. And at surgery, there was 180 degrees twisting of the vascular pedicle, and the ovary was saved. Unlike testicular torsion, presence of flow at Doppler interrogation does not exclude ovarian torsion, rather suggests viability, and if one waits for flow to disappear, the window for salvage may be closed. Here you can see the whirlpool sign of the twisted vascular pedicle. When you swipe your probe from cranial to caudal or caudal to cranial, you can see the whirlpool similar to midgut volvulus. As you can see here, twisted. This is a reliable finding, but not seen in all cases. Here you see a 15-year-old female with ovarian torsion on the MRI, but MRI findings are similar to ultrasound. Here you see the bladder on the coronal view. That's the uterus, and interestingly, it's not in the midline, it's on the right side. And there is this cyst and an enlarged ovary. You may think that this is the left ovary, but it's actually the right ovary. And this is actually the left ovary, which is normal. And this is our right ovary on the contralateral side and associated with a large simple cyst. And on the coronal images, you can see the findings better, peripherally distributed ovarian cysts and some free fluid. And this is the ovary hemorrhagic necrosis. Here you see another patient with ovarian torsion. On the ultrasound, there was a large cyst on the left side. We did an MRI. On the MRI, you can see the normal right ovary, but on the left side, there was a large cyst. We couldn't really identify the left ovary, and on the axial, we can see the cyst with septation, and at pathology, there was extensive hemorrhagic necrosis. Paraovarian cyst torsion can also be seen. It is separate from the ovarian torsion. The ovaries and the tube can be completely normal, and they present just like ovarian torsion clinically. So on the MRI, you can see the right ovary with some follicles, normal left ovary with some follicles, but here you see the cyst outside of the ovaries and also on the coronal projection. And this is how it appears at surgery. It's an hemorrhagic cyst. They were removed. It is usually not possible to make the diagnosis preoperatively, and they are most of the time diagnosed at surgery. So what are the ovarian cysts? The most common ones are functional cysts, follicle and corpus luteum. Follicle, they both measure 3 centimeter or below. Follicles are they enlarge and they consist of the ovum, and then the ovum leaves the follicle and they involute. And sometimes they after the rupture of uh, the rupture site is sealed off and the cyst becomes a thick-walled vascular cyst. These blue and red colors represent the Doppler flow to show the vascularity. And sometimes we don't see the thick wall, but we still see the vascularity in the corpus luteum cyst, and Doppler is very helpful in diagnosing these cysts. These are functional cysts, asymptomatic, and they don't need any follow-up. But sometimes the ovum in the ovary does not leave the follicle, and the follicle continues to grow, and over 3 centimeters it is called an ovarian cyst. Hemorrhagic cysts are typical with internal reticulations, like linear echogenicities, like this one. And endometriomas are also complex cysts with hemorrhage. They usually appear as a homogeneous hemorrhagic cyst, but fortunately very rare in children, and we almost never face with them in the acute clinical setting. So how do they look on imaging? A follicle is up to 3 centimeter, very common. We see them in all children. These are functional cysts. Corpus luteum cyst is thick-walled, as you can see here. It has a typical appearance and small, 3 centimeter or under. And simple cyst, no solid component, no vascularity, anechoic. Hemorrhagic cysts are not simple. They have the reticular content. This is a typical appearance of hemorrhagic cyst, and endometriomas are usually homogeneous hemorrhagic cysts and very rare in children. So what should be our approach to ovarian cyst? What shall we recommend when we see an ovarian cyst? For functional cysts, follicles, and corpus luteum, no need to do any follow-up, they are physiologic. For simple cyst and hemorrhagic cyst, the approach is similar. 5 centimeter or under, no need to do any follow-up. Over 10 centimeter, an MRI is recommended. Between 5 to 10 centimeter, a follow-up ultrasound is recommended between 8 to 12 weeks. The approach to endometriomas is more complex, however, we don't need to worry about that in children in the acute clinical setting. So let me show you some more examples. Here you see a large cyst with thin wall, anechoic, no vascularity, no solid mass. On the follow-up, 10-week follow-up, there is no significant interval change. It measures 6 centimeters, and 1-year follow-up, no change. We are doing a 1-year follow-up, and we ended up doing an MRI because it was persistent, and the MRI shows a simple cyst with thin wall, and there are associated follicles in the ovaries, but this is additional. These are normal follicles. So this is a simple cyst, and these are follicles. Here we see another simple cyst. On the right side, there was flow in the ovary, the venous flow as you can see, and we ended up doing a CT. And on the right side, we can see the cyst, and on the left, normal left ovary, this patient was presenting with right lower quadrant pain, underwent surgery, and there was no torsion or tumor on histopathology. Functional cysts can be better seen on Doppler, but also on the MRI if they are thick-walled. Here you can see the thick-walled cyst. The patient is asymptomatic, and on T2 and on T1 and on the post-contrast images, we can see the enhancement. These areas will appear hypervascular on Doppler imaging. Paraovarian cysts can be seen as in this case, there was this cyst adjacent to the left ovary. Here, here, there was flow in the left ovary, arterial and venous flow, but the patient was symptomatic, so underwent surgery, and there was no torsion at surgery. Hemorrhagic cysts have typical appearance on ultrasound, and we should be confidently diagnose them. Here you can see this is a very nice paper, by the way, you should read, and it summarizes the typical hemorrhagic cysts with their typical reticular pattern and retractile clot appearance. So the star represents the reticular pattern, and the arrows represent the retraction of the clot. Reticular pattern, retraction of the clot. Reticular pattern, retraction of the clot. Reticular pattern, retraction of the clot. And these are all typical. This may be seen sometimes as honeycomb appearance. Here, honeycomb appearance. These are typical hemorrhagic cysts. Let me show you some pediatric. Let me show you examples for hemorrhagic ovarian cyst in children. Here you see a normal right ovary and flow with color. And here is an hemorrhagic cyst with internal reticulations, no solid component, no vascularity. This is a typical hemorrhagic ovarian cyst. And another example with reticular pattern, internal, some retraction of the clot, same patient. Another hemorrhagic ovarian cyst, you can see the internal reticular pattern, and this patient was followed up with an ultrasound on the 12th week, and as you can see, the ovary is back to normal, there is preserved vascularity, and no residual cyst. Another patient with internal reticular pattern, no solid component, no vascularity, typical for hemorrhagic ovarian cyst. And if your sonographer is good, they can show you flow along the splayed ovarian tissue. Sometimes the hemorrhagic cysts may bleed. When they may rupture, and they may cause rupture of the arteries, and they may bleed, and they may be life-threatening. Here, as you can see, that's the left ovary. That's the hemorrhagic cyst, and it's bleeding. That's the cul-de-sac, and there is hemorrhage in the cul-de-sac. So, ruptured cysts may bleed and can be life-threatening. Always check for signs of hemoperitoneum when an ovarian cyst is detected. So I told you endometrioma is very rare in children, and when they exist, they are not presenting as torsion. So it is usually not a clinical challenge for us. But this is a typical endometrioma pattern, homogeneous hemorrhagic cyst. And on the MRI, we have the pearl sign, almost diagnostic for endometriomas. When you do a T1 fat saturated imaging of the pelvis, you can see the cyst very bright, like a pearl. And on the T2, we see T2 shading. Usually, cysts appear hyperintense on T2 because of the fluid content, but when there is endometrioma, they appear dark. So this is called T2 shading, and this is also typical for endometrioma. This is a confirmed case of endometrioma. In the differential diagnosis, we should consider tubovarian abscess. And in this case, this is the ovary. It appears large and hypervascular, and there is preserved flow. Actually, it's increased flow in the ovary. And this is for comparison, left ovary. Small, and I mean normal size, smaller compared to the right side. And I remember the resident who was on call called me for this case and thought this could be the ovarian torsion. Interestingly, although there is increased flow, the resident thought this could be an intermittent ovarian torsion. So after the torsion, there could be reactive hyperemia, according to the resident, but it's wrong. There is no hyperemia in ovarian torsion, even if it is intermittent ovarian torsion. So the topic of this talk is not ovarian tumors, but I just want to give you an idea about pediatric ovarian tumors. It's a little bit different than the adult tumors. In adults, the most common is serosal tumors and epithelial tumors, like serosal mucinous epithelial tumors in this category. But in children, we have the germ cell tumors. Most common is germ cell tumor, and undifferentiated germ cell tumor is called dysgerminoma. That's the most common malignant. For the embryonal germ cell tumors, teratoma is the most common benign tumor. Is most commonly mature cystic teratomas. So germ cell tumors are most common, and among the germ cell tumors, 95% is mature cystic teratoma. So almost all of them. And just to give you an example, embryonal tumors, teratoma, are typical. We see them with typical fat content and sometimes calcification and ossification and cystic component. That's typical. For the undifferentiated, there are no diagnostic imaging features. It looks as a heterogeneous tumor in the ovary, and it's dysgerminoma, the most common malignant tumor. Uh, Diagnosis of mature cystic teratomas can be challenging. Let me show you some case examples. I put this asterisks for fat. They represent the fat. Although they look like hemorrhage, they're not hemorrhage. They are fat. They don't move or with probe compression, and they represent fat. You can confirm the presence of fat by CT or MRI, but on the ultrasound, there is fat fluid layering, and this is completely fat, as you can see here, completely echogenic, and this is completely fat, and confirmed on CT. There is this calcific component here is on the CT. There is also on the MRI, we can see the fat fluid layering. And exceedingly rare, exceptionally, we can see a simple cyst presenting as a mature cystic teratoma, but you shouldn't really consider this. This is an exceptional case, just to keep in mind. So, in the setting of a known or new diagnosis of ovarian tumor and severe acute pain, consider torsion until proven otherwise. After all this, I would like to discuss a little bit on fetal neonatal ovarian cysts and torsion because there are some nuances between the pubertal torsion and the fetal neonatal ovarian torsion. So first, majority of the congenital cysts are functional and resolve spontaneously after birth. Ovarian torsion is the most frequent complication of fetal neonatal ovarian cysts. Most ovarian torsions occur during and after the antenatal period, rarely seen postnatally. So once you diagnose it, it's already too late. Ovarian torsion and necrosis are followed by intracystic hemorrhage. Complex cyst with a fluid debris level indicating hemorrhage is a significant hallmark for the early diagnosis of ovarian torsion. I will show you some examples. So, what do I mean by simple cyst and complex cyst? It was described as anechoic, homogeneous, and thin-walled for simple cyst, solid septa, blood products, debris, thick-walled, and calcification for complex cyst. So let me show you this congenital ovarian cyst. There is no torsion in this case, and we can see a large cyst in the abdomen, and I know that this is ovarian because I have a sign. This is called daughter cyst sign, and it's very reliable, reaching up to 100% in some papers. And when you see this daughter sign, you know that this is originating from the ovary and it's an ovarian cyst, not a lymphatic malformation, not a mesenteric cyst, not an enteric duplication cyst. As I told you, most of the torsion are antenatal, and here we can see this complex cyst prenatally on the fetal ultrasound. It's 2.7 centimeter, relatively large for a newborn, and we did the follow-up early in life, and then we can see that there was actually improvement of the cyst. It didn't look very complex at that time, and we could see a little bit normal ovary. Here is another congenital ovarian torsion example. The baby is born with this cyst with hemorrhagic fluid level. This is echogenic and representing hemorrhage, and this is more anechoic, more simple, representing non-hemorrhagic component. And on the follow-up, day of life 13, there is some improvement. On 12th week, there is interval decrease in size, but still hemorrhagic fluid level. 6-month follow-up and 1-year follow-up, almost completely resolved over 1 year. And this was a congenital ovarian torsion. Remember, a fluid debris level indicating hemorrhage is a significant sonographic hallmark for the diagnosis of ovarian torsion in neonates. This is an indication for the surgeons to intervene and detorse the ovary. Here you see another congenital ovarian torsion case. On the ultrasound, these are follow-up ultrasound imaging for 2.5 years, and on the 4th and 5th year, we were not able to see the ovary anymore. And this is the normal right side for comparison, normal right ovary with follicles. The congenital, in the newborn period, there are a lot of follicles due to the estrogen hormone from the mother, and they appear like the pubertal ovary. And on the left side, we see a heterogeneous cyst it's a complex cyst. And on the 7-week follow-up, we can see the leveling, the debris. This is an hemorrhagic level, and we can see the anechoic simple content better, 7th week. This appearance was confirmed with MRI on 9th week, and there is improvement on 8th month. And on the first year, we start seeing this focus of calcification in the affected ovary, and it persisted to 2.5-year-old. Calcification is can be seen after ovarian torsion, and also auto amputation can be seen, and we can see wandering uh, ovaries in the abdomen. And this was my last slide. Thank you for watching.